not to have the sheet real taut on their body, okay? It doesn't matter the person, you're better off making sure it's a bit loose. It's gonna be easier for you draping wise and all that stuff, but it feels more comfortable to actually have the sheet feel loose in your body rather than pulled taut. It can be constrictive, it's also more revealing, all that jazz. So try to loosen the sheet up. Don't get lost in kind of this idea of like, I don't know, no CD attempt at making things uniform and pretty. And he's up for me. Go. The bigger bolsters, that's a bigger round bolster. So sometimes that can be a disadvantage. All right. Now, I almost did that out of order. I was talking, I hadn't got the knee underneath the bolster underneath the knees, but as soon as I was to the knees, it jumped out at me, right? Now, for the anterior upper leg, working on the lateral quadriceps. So you have 4 quads. The most superficial one is called rectus femoris. So it's the top and middle of the femur. After that, they're all named vastus, just for where they're located. So vastus lateralis loves to get stuck to IT band. This is also a very sensitive area for lots of people. So palms, working from the hip down towards the knee, will be the most gentle way to interface with this area. Okay. And rotated in, that was with no lotion. Lotion distribution again. Now I'm gonna work on an upward angle on all these. So, on an angle, on an angle. My form's pretty much in that V formation here. Working my way down towards the knee. And then I'm gonna stand in the exact same place, but just turn the leg into a different orientation. So the toes were rotated in, the whole hip and leg was rotated internally or medially. And then I set where it's in neutral position. And I do those same applications with more of an L formation of my forearm. Then I'm gonna be on that rectus femoris I just mentioned, and the other quad muscle just underneath of it called vastus intermedius. And I just slowly work my way back up. Now if I externally right now, I'm gonna hold the sheet against the inside of the knee and externally rotate the hip. And now if I do those same applications and I do have to really L formation, my hand will often be contacting their other leg, but then they know where my hand is. Like the back of my hand is touching the medial side of her other knee. And now I'm going across and getting Mara sartorius, vastus medialis, and then also the adductors again. But I'm hitting the adductors at a different angle rather than coming at them from the posterior side of the body, coming at them from the anterior side. It's like anything, we're usually trying to unstick stuff. So if we think about the IT band as a reference, I want to get the lateral quads unstuck from my IT band, and I want to get the lateral hamstrings unstuck from my IT band. On the medial side of the body, I want to do the same thing for the adductors, get them unstuck from the medial quads and the medial hamstrings. Now we've already worked on everything of the lower leg, so I don't need to do anything else here. I'm just doing this because it's a nice transition out of this position. If I want to do anything additionally, this is where that claw is useful. Just draw down on the medial side of the Achilles. There's a lot of extra muscles on that side. Once I find the heel, I can just kind of hold a nice little traction. But it should feel like I'm taking their toes up like this into dorsiflexion a little bit as I do this. There's other things we could be doing here, but we're not going to worry about that quite yet. But there's other ankle mobility things we could consider. Come over other side. Keep toes cozy. Rotate the leg in. This is where you've already heard me say in the past, where I don't even bother with this part of the leg inside line, because I just turn the hip enough to get to IT band either in prone and supine, and I usually save my time in side lying and don't do it there. Okay, a little bit of motion. Switch my angle. If I need to, check in with pressure. That's just right.
That's good.
On the roll there. Well, this is the symptomatic knee. So note what we ended up with, this order of events was ending, not entirely, but the last thing I'm going to work on in terms of the lower body is the symptomatic region. The idea being that ideally I reduce the tone of everything around it, everything that could be neurologically connected to it. That way when I come to it and I try to actually do some therapy, ideally a lot of stuff has already changed. And you may find, in the most ideal circumstances, that would be the case, that by adjusting everything around it, by the time we get to it, there's barely anything left in terms of some asymmetrical tone or what have you. But I just slow down and I'm a little bit more thorough on this side. I'm searching for that attachment. A little higher up. Oh, we can get close.
Yeah.
Okay, right there. Okay. This is where, and this is a little bit above and beyond, but I know where that tendon attachment is. I'm going to hold that while I'm just doing the same applications. So this would be where I'm doing two things at once. Still on it. I'm mostly doing this trying to just be helpful to her, but ideally you get to a place where you are able to kind of be thinking about a few things at the same time. But to start, you gotta just be worried about how you're draping stuff, right? If you can't feel confident about just draping and bolstering, then all the other stuff will always feel like a bigger challenge. I missed a couple of things, dang it. This is where if you forget something in your protocols, then you just have to hit your toes. If you forget something in your protocols, then you just have to remember and then go and balance it out. So I didn't get the hip flexors on the other hip, and I realize that now the client would never know any different, because I'll just feel like I work on the hip on one side and go over and work on the hip on the other side. This is where over the sheet is what we're looking for, and I'm just gonna work my way up. It's pretty hard to miss. You keep your arm in V formation, your hand directed down towards their knees. If I need to, I would find the greater trochanter, and then come just anterior to that. But then I also want to maybe find the anterior superior iliac spine, which is that front hook of the iliac crest. And that's where I'm going to start my pressure. For that spot again.
Yeah.
So I know that sartorius is a hip flexor, an external hip rotator, and a knee flexor. It does all of those things. So I could just, if I'm going to pick the easiest one for me, I'm going to have her just rotate her hip. Maybe turn your hip to the inside, just nice and slow. Relax, come to the outside, as far as is comfortable for you. And just slowly back and forth. On the inside. And the outside. If I wanted to isolate it, now that she's externally rotated, I could have her just push your heel down to the table like you're about to bend your knee a little bit. Yep, good. Now relax and straighten your knee a little and rotate to the inside. Okay, switch, turn to the outside and bend your knee a little bit. And switch, straighten your knee and turn to the inside. And good, relax. And that would be the fancy stuff. Doesn't take a ton of time, but we will get to where that would make more and more sense. Part of it starts with just being able to get yourself planted in this hip flexor region effectively so you can hold pressure long enough to even pull that off. What I have to do as the practitioner for a lot of that muscle energy stuff is I have to be able to hold a nice, long, stable compression. Now this side, I don't need to worry about that as much. It's not the symptomatic side. This would have been the one where it'd be better to be able to assess, confirm how that all feels. But including this hip movement, by pushing the leg back and forth, this is the passive way I can do this. Down at the knee, just push, that's internal rotation, external rotation. And I can have that sync together with this compression and get a lot more benefit and effect here. We talked a little bit before about how chronically short and tight the hip flexors get on people. All right. Come up. Now, in terms of finding their arms here, as said, find their wrist first, undrape. And you can come in with a nice forearm, hand touching the table, angling down. I don't want to be up in the ball and socket joint, the glenohumeral joint. I want to feel like I'm down on the ribs. This is where the anatomy knowledge helps so much. So when you look at those anatomy charts, you'll see usually the superficial group where there's pectoralis major, but then underneath of it is pectoralis minor. If I'm going to make the best use of my time, I'm trying to compress both of those. So having that visual and knowing that they attach down onto the ribs just inferior to the scapula and clavicle, that's what I'm trying to be on. Okay, and I just stand up, I keep hold of the wrist, switch to working on the biceps. This is one of the best examples of, instead of kneading with your hands, doing the push and the pull, I apply pressure with the push and then turn her body to create the torsion. This is still creating the same effect as a knead, but I'm getting all the shoulder rotation happening at the same time. So I'm going to get the fluid movement stuff more connective tissue related effects. Now, same thing I said about the forearms in prone. When they are pronated like this, even in supine, the common attachments for the muscles you're working on are closest to the edge of the table. They're on that side of the elbow. So if I have my application start kind of still pretty much straight down into the table, but it's a little bit towards the edge, not, you know, on what would seem like the medial side of the elbow. That's where I'm going to get the most contact with those structures. Those extensor muscles either work at the wrist or the fingers, including individual fingers. My way down, bend knees. Wrist. With wrist, don't do too much traction stuff. If I do anything, I get my hands on their hand, thumbs down on either the radius and ulna, and just little backs and forth. So I can play with flexion, extension, radial deviation, ulnar deviation, but it's not pulling, and sure enough, I got a pop. And pops are okay as long as it's not a thrust-based manipulation kind of a deal. So when working in these areas, it's not going to be uncommon for you to get both clicks and pops. But what you don't want to be doing is a sudden, like, heavy traction. Squeezes and light tractions with a little bit of joint mobilization. And by that, I don't mean any kind of like attempts to create a pop, but just moving it through its ranges. I know that that's what the wrist should be able to do. It should be able to go into extension, flexion, radial deviation, which would be like abduction, and ulnar deviation, which would be like adduction. Okay. Underneath. Good. And find the other. And so here you have the better angle for this. Or even right over top of the sheet, it works great. Where I just plant my hand, rest my forearm. When I roll the arm, I can feel where the ball and socket joint is and just work my way. I can feel where that pocket is, apply my pressure. Here I do have to kind of lateral side bend. Now the focus, as you see, will tend to be towards external rotation. Everybody gets with their shoulders. The syndrome is called upper cross syndrome, kind of that slouch mechanic. But as far as the shoulder joint and the scapula is concerned, it tends to mean we're too elevated at the scapula, too protracted at the scapula, too internally rotated at the shoulder joint, and too adducted at the shoulder joint. Potentially also too flexed at the shoulder joint. Okay. And the push and pulls. Down. So right here where I'm pointing with my fingers, that's going to be where the common extensor tendon is. And you'll feel it, like that's where the epicondyle of the humerus is. You go over that, then you'll feel like you're officially on muscle. There's a lot of wrist and hand issues that manifest, and people don't sometimes pay attention to them a whole lot because other things are going on in their body. But naturally we use our hands a lot, right? So being able to effectively work here is essential. If you want a tactic of how to facilitate change here the easiest, whether it be when they're prone or supine, you know, get the anterior side in prone and get the posterior side in supine. But anywhere here, especially this half closer to the elbow, once I'm applying pressure, I just include some movements. So we're going to make a fist, and then little circles, one direction, then the other direction. Good, relax. So that's all the finger flexion stuff plus every movement that the wrist can do. Okay, now open the fingers nice and wide and then circle at the wrist. Another direction. Good, relax. Now that's all the extensors with wrist motions. Okay, and now just fingers wiggle around, play piano. And there you go. Doesn't matter initially in terms of, doesn't matter what the hand or wrist issue is, that's a very good starting point to just get all the structures up here on the forearm. Because there's a lot of overlap of muscles that should work at just individual fingers or at all of the fingers or just the wrist. And it makes sense that they'll tend to get stuck together. Nice squeezes. Using my last 3 fingers to create that squeeze. So my middle finger to my pinky.
Also, it was very good. I had 525 on the QR for today, so they are using it. Oh yeah.
Okay. And back underneath. And this is where we would get ourselves seated. Hydraulic stool is a nice thing. Worst case, you can always drop down underneath. Okay, I'm going to go ahead and take the pillow out. Thank you. Put your head back down right into my hand. First things first is getting the hair out of the way. So just draw the hair up. Little rotations. We're doing low rotations with the cervical spine. Getting the hair slowly out of the way. We can make this feel good. I'm creating one side of the occipital base in one palm, the other one in the other palm. Just keep going. And I get myself set with my hands kind of like goalposts. This on one side and the other side. Then I'm going to brace my forearms down into the table. My fingers are contacting as low as I can go on the cervical vertebrae. And then I'm trying to lift the head straight up, not pulling back. I'm lifting the head up off the table and into flexion. That will create the traction. It's the safest way to do it. Don't pull straight back, whether chin goes up. Should go down. And I reset. Have my fingers now more central to the cervical spine. Same lift. And reset. Just at the base of the skull. Try to make sure, I have to look, make sure I keep her nose lined up with her sternum. Same thing. Lift. Now sometimes I can get that to happen all in one glide. But from a more targeted standpoint, I'm thinking about those 3 segments of the cervical region. Rather than thinking about individual vertebrae, I tend to think more in those kind of like what's happening in the lowest part of a region of the vertebrae, the mid, and then the upper. That way. Now for the frontalis. So the forehead has some important muscles here. They're just above the eyebrows. So planting I gather my hands together just like that. Fingertips right on the temples. I find the zygomatic bone, the cheekbone, just in front of the ear. And then good compression. I can just straight down under the forehead. And then kind of let the glide slowly manifest, pulling away from the midline. And then up towards the crown. So away, out and away, medial to lateral, and then up towards the crown. And here we go. Contact in the shoulders, and rock, brush. Now here's going to be the difference for our orientation. I tend to save doing the abdominal work for the end. We could have just done this right as soon as we turned into supine, okay? So, all right, one more thing for your low back. I'm gonna have you bring your knees up, feet flat. There are benefits to both. So I could have had her turn from sideline to this position, and I'm like, okay, we're gonna do one more thing for your low back, making sure their hands are on their tummy or their chest, and then I'm gonna show how we can do this without having to do like the big abdominal drape thing, by just creating a little window here on the side. But either order is fine. My thing is I tend to want to wake a person up a little bit. Let's say they're on blood pressure meds and things like that. It tends to be good to just have them do a little active thing at the end so they're not too dizzy after the fact. So I'm just really conditioned to doing this at the end as opposed to at the beginning. Now here's where I'm going to create just a little U-shaped funnel, right? And I can get access underneath. I'm trying to get as far to the lumbar spine as I can. Okay, adjust the sheet just a little bit here. You can see that's plenty modest, right? Especially if you're in an enclosed room with somebody, but even for you guys to be able to see, like there's nothing, right? So then I just create a nice, no, I'm thinking a couple of things. I want to be pulling the low back away, low back structures away from the spine, but also this forearm is going between the pelvis and the ribs and denting the obliques. I am applying some compression to the obliques with this pull. Okay, so nice pull back, and I'm going to have you turn your knees away from me. And I just hold on for dear life. And now that I'm on skin, a glide is going to happen. She just slowly keeps going. I'm not pushing, I might help a little at times. But slowly but surely right now, the glide is still happening. When the client can feel that, I can feel that. It changes the dynamic quite a bit from even working over the clothes like we have been. Okay, come back. And then one more. Turn. And good. Back to middle. And then I just take that down with me. Swoop around to the other side. See the mechanics a little bit more effectively from this. This one, I mean, you may have to either lower the table, rotate towards me, or get up on that step stool. Back turn. I know that working in the abdominal area is kind of an alien concept and can seem uncomfortable to therapists when they hear that. We'll come back. But this interface, since we're starting at the low back, ends up being a really nice way to introduce the concept. Go ahead. And it being, the thing is that your abdominal muscles do wrap all the way around and attach into your low back. So for a lot of people, the obliques, and there's a muscle deeper to them called transverse abdominis, that may be a big part of the problem. That they don't get addressed and a person isn't going to see benefit, right? Good. Back. And there we go. All right. I'll meet you outside with a glass of water. Off and away.